Happiness. Yes, this is Dr. Srikanth from team MDS CONQUER. Now I'm going to discuss the topic Endoperio lesions. So first of all, when you're talking about an infection may start at one place, okay, and may enter at different places. This is what regularly seen in the human body. So the entry of the infection from the entry point, that is the focus of infection, okay, it spreads to different areas or different systems. Similarly, when you're talking about a dental hard tissue which contains enamel, you have your dentin, you have your pulp over here, and this yellow area inside the gingiva which attaches is called as cementum, and all this area is called as your periodontal tissue. Okay, so particularly this area is called as periapical periodontal tissue. So this is what the structures that are present in the dental hard tissue, that is the tooth. So now we are talking about the relationship of pulp and periapical. Okay, here you have pulp and you have your periapical tissue or periodontium. Okay, so first of all we need to talk about what are the communications that are present. So whenever you have a communication, okay, then only the infection from one area, that is the pulp, will spread to periapical or periodontium, or periodontium will spread to the pulp. So that is the relationship between the pulp and periodontal tissue we are going to talk about. Okay, so when you're talking about this particular content, the main important aspect that you have to make a note is what are the communications. The communication number one is apical foramen. So apical foramen is one communication where the pulp is going to communicate with the periodontium. And the second communication you can see here, this is the whenever there is a gingival recession, you will lose cementum over that particular area. The yellow color cementum is lost and your dentinal tubules will be exposed. So the first root is apical foramen, the second root is dentinal tubules, and sometimes apart from the apical foramen you will have your accessory canals, you will have your lateral canals, you will have your furcal canals, so all the extra canals. Okay, so the one communication between the pulp and periapical is apical foramen, the second communication is the dentinal tubules, and third communication are the canals. So these are the communications by which the infections from one area will spread to other area. Means pulpal infection can be spreaded to the periodontium, periodontal infection can be spreaded to the pulp, because they have communications. So these communications are prime reasons for the spread of infection. So according to Kohen, okay, the classification according to Kohen says the classification of endoperio lesions can be categorized into primary endodontic lesion, means which has only endodontic origin. Primary endodontic, secondary periodontal, means it started as an endo, but with all the communications, with any of these communications, three communications we have learned, it has spreaded to the periodontium, but initially it has started in endo. Then primary periodontium, only periodontal, and primary periodontal, secondary endodontic, means initially it started in the perio aspect but spreaded to the endodontic lesion. And the last one, this is very very important, a case which you cannot judge whether it is primary endo or primary perio but has endoperio lesions, means two separate lesions, you are not in a position to conclude it as whether it is primary endo or primary perio. Such lesions will be comes under the true combined lesions, that is endo plus perio. So this classification is very very important, because in recent aims and recent NEET we have seen a decent number of questions by just giving the clinical scenario and asking you to identify which type of lesion it is, like the diagnosis of endoperio. The first important aspect that you have to make a note is primary endodontic lesion. I'm clearly stressing it, primary endodontic lesion. Okay, so primary endodontic lesion means that can be a deep caries, Okay, so that can be, you can see in this radiograph, you have a caries which is approaching to the pulp, and there is pulpitis. Okay, so there is pulpitis, the pulp is inflamed. Then from the pulpal, with all the chances, what are the chances? One communication is by the dentinal root, dentinal tubules. The second communication can be by the furcal canals. The third communication can be by the apical foramen. It spreads to the periodontium, it damages the periodontium, it can damage the periodontium also, right? So such cases are called as primary endodontic origin. So if this case has periodontal pathology also, then we can call it as primary endo and secondary perio. If it has only endodontic origin, then it is called as primary endodontic lesion. The second one is primary periodontal. Okay, so there is a deep pocket here. You can see there is a deep pocket. You have a bone loss here. You can clearly appreciate on the radiograph, you have a bone loss here. So by which you have a pocket, and the infection starts from the periodontium. Okay, if this infection starts from the periodontium, and if in future if it is going to hit the pulp also, means you don't have a dental caries, you don't have any signs of or any etiology for the pulpal infection on the radiograph or on the clinical scenario, but the pulp is damaged because it has a deep pocket, which indirectly gives, means it has started as a primary periodontal lesion, but further it has caused endodontic problems also, means some pulpal disease. So it is called as primary perio and secondary endo. Then I have discussed a combined lesion. Okay, means it has the problem from both the sides. It has a pulpal problem and it has a periodontal problem, which doesn't have a communication, which they are not coordinated to each other in the clinical scenario, because you can see a deep pocket over here. Okay, and you can see a pulpal infection over here, but it's not communicated, right? So it's a pulpally it is different and periodontally it is different. You cannot come to a conclusion that whether it is primary perio or primary endo. Such lesions are called as combined lesions. So as already discussed, what are the communications between the pulp and the periapical? The pulp and periapical communications are either by the dentinal tubules, okay, or either by the lateral and axillary canals, or either by the apical foramen. So these are the three communications which causes the pulpal infection to spread to the periapical and the periapical infection to spread the pulpal areas. So now we'll learn some integrated way of handling this. So there are some etiological factors for the causation of the endoperio lesions, and similarly you have some contributing factors. So what are the contributing factors? If you have a poor endodontic treatment, your endodontic treatment is not great, okay, so it may lead to primary endo, it may lead to endoperio lesion in the future. Okay, it contributes to. And coronal leakage. Coronal leakage is the most common cause for the failure of endodontic treatment, because as we know that we give a temporary restoration once the BMP is done before the obturation, and the minimum thickness of the restoration that is required is 3.5 millimeters. Okay, the cavit whatever we give, okay, so cavit or IMR we give, that's right. So that holds the coronal restoration, right? That's the coronal restoration, and the minimum thickness that is required is 3.5 millimeters. And it is the same reason why whenever you are planning for post endodontic treatment, make sure your gutta should be sealed up to the canal orifice levels. Okay, so by which you can provide a proper coronal seal. So coronal seal is mandatory, because if there is any damage of the coronal seal, there are high chances that your endodontic treatment is going to fail. Okay, so similarly the other contributing factors are the trauma. You have your root resorptions, you have your perforations, developmental anomalies, particularly like grooves, palatogingival grooves which are extending onto the root surface, because whenever a groove that is extending onto the root surface is going to provide a pathway for the bacteria to move easily. Okay, so whenever the things are going on the root, what is root area called as? That is periodontium, right? So there are high chances that the endoperio lesion can form. Similarly, a cracked tooth syndrome. All these are contributing factors. But coming to the etiological factors, the major etiological factor of the organisms, that is bacteria. Bacteria is the most common cause for the pulpitis, and similarly bacteria is the most common cause of endoperio lesion. Here we have some important things that you have to make a note. So among the list of the bacteria, the anaerobic bacteria causes 90% of infections. Okay, and similarly you can make a note that spirochetes are associated with both endo and periolesions. Okay, your spirochetes are associated with both endo and periolesions. And when you compare with the number of spirochetes, the spirochetes will be more in the case of your subgingival plaque when compared with the endodontic origin. Okay, and make a note that L forms. Okay, L forms of bacteria, we'll learn about what are these different forms of bacteria. So L forms of bacteria are present more in endo when compared with the perio. Okay, you have your fungal infections. Okay, that is candidiasis. You have your viral infections, that is herpes simplex, cytomegalovirus, Epstein-Barr virus type 1 are associated with both endo and perio lesions. And similarly, there are few other non-living organisms, non-living pathogens that can cause this. Okay, that can be a foreign body, or your dentin or cementum chip, or your improperly removed amalgam restoration, or your root canal filling material. So all these are the materials, okay, extrinsic materials. And similarly you have some intrinsic agents, like these are the different crystals, different types of bodies, and which can be seen in the histological sessions. I'll show you the diagrams, which are very very important as a diagram based question. So as already discussed, you have some live pathogens, you have some non-living pathogens. So as already discussed, bacteria is a live pathogen. Make a note about your fungus. Candidiasis is the most common. Your bacteria, you'll talk more about spirochetes when you want to differentiate endolesion from periolesion, because in periolesions your spirochetes will be more. That is about your Treponemia denticola, okay, which is a spirochete which is most commonly seen in the periodontal lesions when compared with the endodontic lesion. So whenever you have a communication between endoperio, so these bacteria which are present in the periodontium will go through the passages, okay, and will reach the pulpal. So by which you can diagnosis by using some microbiological tests, you can diagnosis roughly as endoperio lesion. Similarly, you have your viruses. Okay, the viruses can be herpes simplex virus, or cytomegalovirus, or Epstein-Barr virus. So all these viruses can be seen in the case of your endoperio lesions. So as already discussed, okay, these are the non-living pathogens which are going to cause the endoperio lesion. Okay, so these are the foreign bodies. Okay, so already discussed, like the leftover gingival retraction cord will cause inflammation, will leads to the bone loss, and will cause the bone loss leading to the periodontal problems. Okay, so you can make a note. Okay, this is a well-known histological slide, epithelial rests of malice. Okay, so please do identify this. I think, like, arrow based questions, I think they're very rare to ask, like marking by pointing a particular area and asking you to identify the histology. Regularly they are going to give a histological slide that is given in the recent NEET 2020, which has given on general histology. But of course your oral histology is nowhere an exception. So I just want you to make a note about these diagrams and please try to identify them. Okay, these are the cholesterol crystals, okay, which can be seen in the periepical radicular cyst. Okay, radicular periepical cyst. These are Russell's bodies. Okay, so please do try to identify this unique Russell body. And these are Ruston Highland bodies. Okay, so you can identify them. So please do that. These are the questions which are commonly seen in your oral pathology, but please do make a note about the histological slide too, because there are high chances that they can throw a histological slide and ask you to identify it. Okay, so these are leaden crystals. Okay, and I have discussed about all the contributing factors: your poor endodontic therapy, poor restoration that is due to the coronal leakage, your trauma, resorption which can be internal or external, developmental anomalies. Particularly we need to talk about palatogingival groove, or any sort of grooves which are extending onto the root surface, perforations, and the root fractures. So all these are going to be the contributing factors. Means most of these contributing factors, they provide a gateway for the bacteria to move from one place to other place. Regularly you have the gateway which moves from pulp to periapical. You have three gateways which we have learned. So these these are the contributing factors which are going to provide other gateways, or which are going to provide an easy access for the infection from one area to move to other areas. Okay, so you can see a poor endodontic treatment. So here you don't have your proper obturation, the obturation is not good, so you have so much of space for the bacteria which is in the periodontium to enter into this particular area, or for the bacteria which is present here to enter into this particular area. So the communications has increased well. Similarly the condition here, okay, your restoration, your poor endodontic treatment, okay, these are the reasons. And coming here, this is a poor restoration. I was talking about like sealing of your gatapacha is very important. Once you seal the gatapacha, if you take like your system, so this is where you're going to obturate, right? So you're going to keep gatapacha here until this area. So these are the orifices. Make sure you keep gatapacha, but the new concept says that the old concept says that your orifice should be filled with gatapacha entirely. What new concept says that your orifice should be filled uh, 2 millimeters below the gatapacha, and this 2 millimeters you have to seal with a good sealant. Okay, most probably you have to use a GIC. So you will get a seal here. So once you get a seal here, over that you are going to do your post endodontic treatment. Okay, so in most of these cases here you can see your gatapacha is not sealed well. Okay, your post endodontic restoration was not proper. Okay, so this is a coronal leakage. You can see a resorption here. Okay, you can see an internal resorption over here. You can see this internal resorption. Mostly these internal resorptions are due to trauma. Okay, and you can see some external resorption over this particular area. Maybe these external resorptions can be maybe one of the etiology for these external resorptions can be your orthodontic treatments. Okay, so this is an external resorption case and this is an internal resorption case. So you can see a perforation, okay, improperly placed. I was talking like whenever you treat your molars, okay, make sure that your post length should not be more than this particular area. But this is the long axis how you have to keep the post, right? So but the post was kept in a different direction, okay, which leads to perforation. It's almost the case is almost the similar. Okay, so whenever you're keeping a perforation, you're giving a chance for the bacteria to move from one area to other area. So that's these are again contributing factors. Your fractures in the similar way, you're giving a bacteria to chance to move. Okay, so developmental elements, I was talking about the palatogingival groove. You can see this, the palatogingival groove is extending, means normally you don't have any communication for the bacteria, but when you have a deep pocket and a palatogingival groove, okay, then the bacteria has easy passage. Okay, so all these are going to be contributing factors, and make sure you have a decent coverage over the diagram based questions. So whenever a radiograph or a clinical photograph is given, like by seeing the options, you need to get some findings, get some analysis, get some ideology or the diagnosis and the treatment plans. Like for example, in this palatogingival groove, okay, so what you have to do is apart from, like, you have to see whether it is going to cause the pulpal disease or periapical disease. If it's not causing anything, make sure you provide access for this and you seal it with GIC, so the passes can be overcome. Okay, so such a case, like, you have to find a way to overcome this contributing factor. So what are the different things that are used for this particular diagnosis? Okay, so diagnosis is very important. One is visual examination, that is clinical photographs, and the second one is palpation. Okay, it is tender on vertical or tender on horizontal. Okay, you have to see both. Okay, so your palpation will give some idea about the inflammation areas. Your percussion, vertical percussion, is going to it's going to help in checking the periapical inflammation. Okay, so your mobility will helps in testing the periodontium. Your radiographs may give some clue about the extent of dental caries approaching the pulp, whether it is a pulpitis, or it can give an idea about the bone loss. Your pulp vitality is going to give the viability of the pulp. Okay, and your probing is going to give the viability of periodontium. Your cracked tooth test, your tooth slot, all these things are useful in finding out is there any chance of fracture? Your fistula tracing is generally done by with the gatapacha. Mostly you use and like whenever you see a fistula or whenever you see a sinus tract opening, make sure you insert some gatapacha in it. Okay, preferably 25 number gatapacha is inserted in it, and you have to take a multiple series of radiographs from different angles by which you can conclude that this infection is from this particular tip. Okay. So there is one more classification which is based upon the treatment. Okay, so the classification says that requires only endodontic treatment, means it is only endodontic lesion. Requires periodontal treatment, only periodontal lesion. Requires both treatments, so it's going to be endoperio lesion. So like whenever you have to go, you know the cases where you have to go for only endodontic treatment. For example, I'm going to give an example. You have a teeth, okay, and it has a sinus opening into the gingival sulcus. So what you have to do, you have your 2-1 with sinus opening in the sulcus. So what you have to do, you have to trace the sinus opening. So take a gatapacha, keep in the sinus opening, and you can trace it. Like if it is going towards the periapical area, then you have to check the vitality of the teeth. So mostly the vitality will be non-vital, right? So it's an endodontic lesion. Okay, it's an endodontic lesion. So what is the treatment of this case? You have to do root canal treatment. So do root canal treatment. In most of the cases, the root canal treatment is going to be the permanent treatment for this case. And whatever the sinus tract, when the root canal treatment is done, when the infection is removed, so the sinus tract will heal by its own. The healing of sinus tract will be done by its own. Okay, so this is a case where only endodontic treatment is required, right? And the second one is periodontal treatment. Like whenever you diagnose a periodontium, periodontitis or some periodontal pocket on a particular teeth, then you do only perio treatment. Okay, so and you have to check the vitality. In most of the cases, in this particular case, the vitality will be positive. Okay, the pulp is normal, but you have the periodontal problems, so treat the periodontium. It's the only periodontium. And the next one is a combination of both. Okay, it's already discussed. Like you have your primary endo and secondary perio, or primary perio and secondary endo. So all these cases you have to do a combined treatment. You have to do a treatment which is of combination, and preferably what most of the studies say that when you have an endoperio lesion, make sure you complete the endo treatment first, because the prognosis for the endo treatment will be fast. So root canal can be done in single appointment or in 1 or 2 appointments, but when you have a bone loss, your periodontium to regenerate or reversal the bone loss, it's going to take lots of time, right? So endodontic treatment has to be done first, followed by the periodontal treatment in most of the cases. So this is a basic difference. I mean, you're well versed with this. I'm just going to make a note. So the etiology for endodontic lesion is the necrosis of pulp, and the etiology of periodontal lesion is the infection and the inflammation of the pulp. When I'm talking about the nature of the pain, it is acute and spontaneous. Most of your periodontal pains are dull and chronic. And coming to the swelling regularly occurs in the periapical abscess, which is a diffused, and this is occurs in the attached gingiva, which is a localized one. So when I'm talking about percussion, the percussion will be like, it will be positive in vertical direction, it will be mild in lateral direction. Okay, so and the probing depth is going to be normal, is going to be more than the normal here. Okay, so how do you diagnose the sinus opening? The sinus opening, the gatapacha pointing leading to the apex of the teeth that is involved, it may move towards the sulcus of the teeth that is involved. Okay, so the mobility is localized in nature, and it's going to be very, very rare in the endodontic lesions, but it is more generalized in the nature. Your junctional epithelium is normal, your gingiva is normal, the treatment is root canal. Your junctional epithelium will shows apical migration, your gingiva will be inflamed and recession, and here it's a periodontal lesion. Sometimes because of the communications, it can be primary endo to secondary perio, and primary perio to secondary endo. So as already discussed, the primary thing that you have to do is endodontic therapy. Treat endo first, followed by you're going to do all the periodontal things. So sometimes there are a few other extraordinary things that you have to do. That is the hemi-session, radicession, bicuspidization, all these things. I'm just going to post the. You can just check the photographs. Okay, so this is an endodontic surgery. Okay, which is done here. You can see a big periapical lesion with lots of bone loss. Okay, the endodontic lesion was the endodontic surgery, periapical surgery was done. So of course, whenever you have only periodontal problems, you have to do your periapical surgery, that is the deep scaling or the root planing. And these are the extraordinary cases where you can clearly see here you have a bone loss or a particular tooth, okay, or particular root of a teeth. Okay, so it's very difficult to save the entire thing. So what better you can do is you can save this half, that is called as hemi-section. Okay, so this is a hemi-section case, okay, where you can save the half, you can remove the half of the teeth, you can see an edentulous area, and a bridge is placed. So when you can do a hemi-session, okay, hemi-session is I mean, the indications of hemi-sessions are very simple. So whenever you have a bone loss, okay, severe bone loss on a root, on one root, on a root, okay, or we have a fractured root, or you have a blocked root, means where your endodontic treatment, you are not able to do an endodontic treatment because of some calcification or something, or you have a perforated root. Okay, so all these cases it's better to remove one root. Okay, so save the one and remove the other. Okay, so these are the things that you have to regularly do. So here it's a one more case that is called as bicuspidization, where one molar, okay, because you have your furcal bone loss, okay, so you cut like this and make it into two premolars. Okay, so one molar is broken into two premolars by going through the furcation. The best indication is whenever you have a furcal perforation, or whenever you have a severe bone loss in the furcation. Okay, in such cases you can go for this hemi-section, or you can go for this bicuspidization or bisection. Okay, so I'm done for now. Signing off, Dr. Srikanth from team MDS CONQUER. Love learning with MDS CONQUER.